So I'm going to introduce our next three speakers now. First of all, I'm pleased to introduce Mark Petticrew. He's a professor of public health at the London School of Hygiene and Tropical Medicine. He's also director of the NIHR Public Health Policy Research Unit and leads one of our work packages. We'll then hear from Professor Jamie Pearce, Professor of Health Geography at the University of Edinburgh. He's also co-director of the Centre for Research on Environment, Society and Health and leads the Scottish Graduate School of Social Science. And then we'll hear from Professor Rachael Murray, who's a professor of population health at the University of Nottingham. She has wide-ranging interests, but many of them are in the area of smoking cessation, where she's done a number of large studies. And also she's looked a lot at the promotion of unhealthy commodities through the media. So Mark, you're starting us off, and thank you very much.
Thanks very much, Linda. And yeah, thanks. Great opener, Greg. As Greg says, if we could have the next slide, please. Research in the tobacco industry by Anna and Greg, Jeff, who are speaking later, has exposed the strategies of the tobacco industry, which include generating doubt, undermining the evidence, lobbying governments, shaping policy responses, shifting responsibility to smokers, and so on. And I mean, I think the alcohol industry probably taught the tobacco industry some of these tactics. So I see someone has put in the chat that the motor industry was also an early adopter and led the way. The chemicals industry as well. If you read David Michaels and others' work and Merchants of Doubt, you can see that the chemicals industry was in the space as well. But developing these tactics and sharing them between them. By the last bullet point here, owning the public space, I mean, where harmful industries present themselves as a public voice, in this case on smoking and health, but other industries do this as well, presenting them as a public voice on health, moving into schools, moving into workplaces, providing educational campaigns to the public and so on. These are very common cross-industry strategies, and they're not specific to the tobacco industry, as Greg says. And they're part of, I think, the information environment. Linda and Greg both mentioned environment. So I think what I want to talk about is the information environment. Next slide, please. So what I want to look briefly here is an example where the alcohol industry does all of this. It undermines the evidence, owns the message, shifts responsibility to consumers in the way that Greg outlined. And in this case, it's where the alcohol industry provides health information to the public on health harms via alcohol industry funded organisations like DrinkAware in the UK, DrinkAware in Ireland, DrinkWise in Australia, and so on. Well, we've analysed alcohol industry information and actually misinformation from a lot of these organisations, and we've looked at three areas in some depth: cancer, pregnancy, alcohol consumption, pregnancy and fetal alcohol syndrome, and alcohol and cardiovascular disease. I'll stick mainly to the first two today, just in terms of time. Next slide, please. So in terms of the, I suppose it goes back to what Greg talked about earlier, the pollution of the discourse. The alcohol industry has polluted the discourse and the evidence space around the risk of cancer from alcohol consumption, on which the epidemiological evidence is undeniable and it has been clear for decades. But the alcohol industry disseminates information via a number of organisations, front groups, and some of them charities like DrinkAware, to the public. And this information is quite problematic, very problematic. A couple of years ago, we collected and analysed all the publicly available information on alcohol consumption and cancer, which was put out via websites and information sheets and so on from 27 industry or industry-funded organisations. They're sometimes called social aspects, public relations organisations. So these are international organisations. We analysed their websites, documents, and the other health guidance that they put out about cancer. Next slide, please. And we identified three main strategies used by these organizations. Bullet point, yeah, thank you. It wasn't the next slide, it was the next bullet point. Yeah, so denial and omission and disputation of any link between alcohol consumption and cancer, or selectively omitting the relationship. Next bullet point. They would distort the evidence. So in other words, they would mention some cancer risk. They would acknowledge that there's some risk associated with alcohol consumption, but they would misrepresent that or obfuscate the nature or the size of that risk. Next bullet point. Or they would distract from the evidence by focusing the discussion away from the independent effects of alcohol consumption on cancer. So they would focus the discussion away to smoking and alcohol, for example. So next bullet point, please. Breast and colorectal cancer were the most common sources of information that we found. I think because of the most common cancers, the alcohol industry particularly focuses on misinformation around breast cancer because they're concerned about not scaring the female market. All of this misinformation is doubly concerning, I think, because DrinkAware, for example, uses similar sorts of, or the materials that we analysed include DrinkAware materials which are used in schools in the UK and in Ireland. So this is one sort of strategy for normalising alcohol consumption and putting out misinformation about the harms. It's to use schools and children as a sort of a target for this health misinformation. And just interestingly, I talked about Diageo, but Diageo actually funds a program in schools which has been hugely widely disseminated called SMASHED, which is in 25 countries at the minute, including the UK. And this Diageo itself says that it's reached 1 million children with its misinformation. We analysed the materials that are disseminated through this program called SMASHED. They're very problematic, and as I say, normalise alcohol use and contain misinformation about cancer. Next slide, please. I think it's quite useful here. What we're seeing is a form of denialism, but it's quite useful to distinguish between hard denialism and soft denialism. These are terms that are often used in discussing fossil fuel misinformation. So hard denialism would refer to an explicit outright denial that fossil fuel consumption, for example, is causing climate change, or outright denial that smoking causes cancer. Whereas soft denialism is becoming much more common. And that's where an industry appears to accept the science, but then undermines it by pointing to other possible causes or by undermining the science in other ways. Sorry, my voice is going. Next slide, please. So this is just an example of hard denialism in relation to smoking from Mike Pence, who you'll remember as former Vice President of the States. And he said in an op-ed in 2000, time for a quick reality check. Despite the hysteria from the political class and the media, smoking doesn't kill. In fact, 2 out of every 3 smokers does not die from a smoking-related illness, and 9 out of 10 smokers do not contract lung cancer. This sort of formula, this particular statement, which appears scientific and epidemiologically based, is another form of denialism. I mean, it starts with hard denialism and then appears to marshal scientific facts to back it up. It's quite a common argument, which is not just used by the tobacco industry. Next slide, please. We see a very similar argument used by DrinkWise. For example, not all heavy drinkers get cancer. Just as Pence said, not all smokers get cancer. DrinkWise, the Diageo-funded alcohol harm reduction organization in Australia, says that not all heavy drinkers get cancer, as multiple risk factors are involved in the development of cancers, including genetics, family history of cancer, age, environmental factors, behavioral variables, as well as social determinants of health. I think this is quite an interesting statement because you see several things going on here at once. Some of these are unmodifiable determinants, genetics, family history. The genetics argument was very commonly, and it still is very commonly used by the tobacco industry. And it's used by other alcohol industry organizations. And these all represent what have been called alternate causality arguments, where an organization appears to accept the science, but it proposes a number of alternative suggestions. So we see the DrinkAware quote at the bottom does just this. So acknowledges this was on its website that alcohol causes cancer, but then it says, in effect, but it might be because you're female, or this is to do with breast cancer. We know that breast cancer is age-related, so it might be to do with your age. These are all factors beyond our control, etc., etc., etc. So in effect, what it's saying is, well, alcohol causes cancer, but lots of things cause cancer. Don't get too concerned. It's a bit like Mike Pence's tobacco industry arguments, but applied to alcohol consumption. Next slide, please. Just very briefly, we know that these sorts of doubt-promoting messages work because we trialed them in an RCT in a study led by Nathan Manny. So we know that these messages are very effective in creating doubt because in the RCT we compared these industry messages relating to fossil fuels, smoking, alcohol, and sugar-sweetened beverages, and we compared them to clear, independent statements about risk. And the industry, the statements from industry did actually increase the uncertainty which people who read the messages felt about the nature of the risk. So next slide, please. I mentioned selective omission of information. This is very common in industry materials. So this is an infographic from DrinkAware Ireland about alcohol harms. So you can see here that they've managed to hide the risk of breast cancer by not including it, and by only having a man. I mean, men do get breast cancer, but it's very uncommon. So DrinkAware have managed to avoid directly addressing the issue of the risk of breast cancer. They've also, by including only a man, managed to avoid mentioning pregnancy or fetal alcohol syndrome either. This is more misinformation in this misinfographic. Next slide, please. This leads me to another form of pollution of the public discourse, if you like, and to another form of denialism. The alcohol industry carefully and quietly engages in fetal alcohol syndrome denialism. It undermines the chief medical officer's guidelines in the UK, actually, and guidelines in other countries on drinking in pregnancy. Now, if you know the CMO's guidelines in the UK, you'll probably remember that if you just look at the first blue bullet point here, they say, if you're pregnant or think you could become pregnant, the safest approach is not to drink alcohol at all, to keep risks to your baby to a minimum. That's because the evidence is still somewhat uncertainty. The alcohol industry, however, has constantly, in many countries, attempted to put out the message that you can drink in pregnancy, you just shouldn't drink heavily. So that's the alcohol industry message. When you read that message, you know that it's undermining the evidence and it's promoting an alcohol industry friendly argument. Next slide, please. So that's why I was very interested to see on the DrinkAware website last December, this document, or this quote from about alcohol and pregnancy. If you read the heading, drink heavily while you're pregnant and it could affect your baby's health. This is pretty disgraceful, I think. It's an alcohol industry argument which is promoting, in effect, what it would call moderate or light drinking in pregnancy, and saying it actually only matters if you're drinking heavily. This directly undermines the CMO's guidelines, which is, I've put up again, the safest approach is not to drink alcohol at all. Of course, it's gone from the website now, because what I've noticed tends to happen is that this sort of misinformation, it comes and goes from these organizations. So they're constantly changing and shifting. So they not only talk out of both sides of their mouth at once, they do it at different times and in different ways. So this is all part of the pollution and the misrepresentation and undermining of the evidence that we discussed earlier. Next slide, please. And it's a classic tobacco industry tactic, sowing doubt by claiming there's uncertainty about the causes and the mechanisms. The fossil fuel industry disputes climate change. The alcohol industry sows uncertainty about alcohol and cancer, about alcohol and drinking during pregnancy. The sugar industry sows doubt about sugar consumption and obesity. The asbestos industry, mesothelioma, The gambling industry disputes causality, demands perfect evidence, and disputes the evidence, and every other harmful industry that you can think of, harmful commodity industry that you can think of. Next slide, please. So, Greg mentioned pollution of discourse by industry, and to help you recognize industry arguments, the ones that are used to delay and derail effective policies, I've come up with harmful commodity industry bingo. I'm aiming to have it in all good toy stores by Christmas, and it reflects all of those industry arguments that pollute that discourse. The argument that we shouldn't do anything because the problem is declining. That's problem deflation. Don't worry about underage drinking. Underage drinking is declining. Middle of the top row, an emphasis on behavior rather than harms. We often see this in relation to drinking or smoking and eating, that it's not the product, it's the individual behavior. The emphasis on information and education as opposed to more effective interventions, and so on. So I think that's it. Next slide, please. Final slide. Further reading, if useful, you can note our new book on the commercial determinants of health in the bottom row there. So that's a quick puff for that. Next slide, please. Final slide is just my funding and acknowledgements. Thanks very much, everybody.
Thank you very much, Mark. That was great. I'll hand over to Jamie.
Thanks, Linda, very much. Good morning, everybody. Yeah, I'd like to pick up on some of the themes we've been hearing about from Mark and Greg already, and bring what I'm calling here a place-based approach. I think it chimes very nicely with some of the comments that Greg made at the start of the session. So two things I'd quite like to try and get through here. Firstly, think about how we can intervene in places to improve health and reduce inequalities. So there's lots of examples we can draw upon where place-based approaches have been used to try and improve mental health, enhance well-being, and also, as we'll talk about more specifically, address non-communicable diseases. The second thing I'd like to do more particularly, though, is some thoughts on how we can apply a place-based approach to address the commercial determinants of health, or perhaps more specifically, disrupt some of the channels that Greg and Mark have been talking about already. So if we could just move on a slide, please. What I'll start off by doing is just say a few broad comments around place-based approaches and the sorts of ways that we've intervened to try and address and improve health and inequalities. We can move on, please. So this diagram gives a broad sense of some of the factors, place-based factors that have been applied and used in policy making to enhance health and reduce inequalities. You can see on the left here what I've grouped around and called the opportunity structures. So some of the sort of infrastructure that we have in our local communities that are important for health and the social determinants of health: housing quality, physical spaces, green spaces, air pollution, services, employment structures, for example. And then on the right-hand side here, the sort of collective social functioning and practices of places. So sort of the less tangible aspects of places, but the other things that we know are important. So levels of social capital, the connections within our communities, the levels of crime, and so on. Just move on a bullet point, please. But what's missing from this agenda in terms of place-based approaches to health traditionally has been thinking through the commercial determinants of health, specifically the role of the commercial sector in driving place-based determinants of health. That's what I'd like to pick up on today. If we could move on, please. It's quite surprising, I think, that there has been this oversight of considering the key commercial determinants of health channels when we think about what those channels specifically are. So we often think about some of the key drivers here around availability of unhealthy commodities, the local availability, driving demand, shaping the norms in terms of consumption, of course, a highly place-based aspect of health. Secondly, promotion and marketing. Again, often this is performed by large multinational companies in terms of geographically targeting messages, marketing campaigns, and the tuning approaches and marketing strategies to particular local contexts. And then thirdly, in terms of pricing, it's some work that we've done quite a lot on as part of Spectrum, is looking at the spatial differences in pricing structures of unhealthy commodities, for example, across deprived and non-deprived parts of the country, or even across the same city. And so really what I'm saying here is that these three pathways are highly geographical, they're highly spatialized, and lend themselves really well potentially to a place-based approach. And what I'd like to do here is, largely because of time, is focus on availability, just one of these particular channels, but also more substantively, this is an area which hasn't had a lot of attention from a policy perspective. So I think it's a particularly interesting one to try and explore. If we could move on, please. So let's turn to some of the evidence base in terms of place-based approaches to the commercial determinants of health, and think about what we know based upon the existing evidence. If we can move on, please. So we're going to start by looking at some of the research we've been doing in this area. We've been working on looking at availability of unhealthy commodities, mostly in Scotland, but also in some instances across the UK, something we've been doing for a number of years. And broadly, what this work is showing, that there's some clear connections between the availability, the local availability, the neighbourhood availability of unhealthy commodities, and then with behaviours, related behaviours, health outcome, and also in terms of inequalities. And the evidence seems to be pretty consistent that the greater availability, particularly of tobacco and alcohol products, leads to greater consumption and uptake of those behaviours, less chance of cessation in terms of tobacco and smoking, and an increase in inequalities. And we see this consistently for both adults and for children. If we could move on, please. And then this particular study to draw your attention to, if you're interested in this area, I think probably it offers the most robust evidence base for this, where we've looked longitudinally and actually tracked, in this case, pregnant women over time, and looking at their changes in behaviour and how that relates to the environment, the local availability of tobacco retailing, and shows, I think, quite convincingly that there does seem to be an association, that you live in a community where there is a great deal of availability of these products for both alcohol and for tobacco, then this does seem to influence behaviour. If we can move on, please. But it's not just our UK research, of course. There's a huge international literature here, and this systematic review with relation to tobacco brings this all together really nicely. So this is the systematic review and meta-analysis shows, I think, quite convincingly that that if you have an environment, a neighbourhood with less availability of tobacco, then tobacco use seems to also be lower and leads to better health outcomes. So the summary there seems to be quite strong evidence internationally, as well as what we found here in the UK. If we can move on, please. It's not just health. Broadly, there's evidence here in terms of population health, commercial determinants of health. These place-based approaches to commercial determinants of health also seem to matter for health inequalities and equity. Could move on, please. We see this in Scotland, the work that we've been doing over the last few years. This is simply just looking at the distribution of tobacco retailers and alcohol retailers across Scotland, and what you see is pretty convincing social gradient, in that the most disadvantaged neighbourhoods and areas and parts of Scotland have considerably higher availability of both tobacco and alcohol retail, and you see this consistent trend when you map it over time as well. You can move on, please. And perhaps more interestingly than just looking at where the retailer is actually looking at the everyday experiences of people, and that's what we did in a study that's been looking at about 700 children who live all across Scotland. We've given them a GPS to follow where they go and sort of look at their everyday environments. And broadly, what we were finding is that all children in Scotland do seem to have a pretty significant dose or exposure to both tobacco and alcohol retailing in their everyday environments as they, for example, travel from home to school. But importantly, there's a really significant gradient amongst disadvantaged compared to advantaged children in Scotland, with children from the most income deprived parts of Scotland having around about 7 times more exposure to this case tobacco retailing than children from affluent areas. So it's interesting to see where children go and their everyday experiences and the very unequal experience they have of toxic environments in Scotland. If we can move on, please. And just to make the point, it's not just looking at availability, this rather complex graph. I won't ask you to take it all in, but just to make the point that it also matters in terms of when we look at behaviours and health outcomes in terms of equity. So we also found an impact of greater availability, in this case, alcohol availability. Found this was more pronounced, the effect was more pronounced amongst low-income groups. So here we can see that availability here is affecting the probability of exceeding UK alcohol guidelines, but this effect seems to be greater amongst the most socially disadvantaged. So not only the socially disadvantaged populations have greater availability, but also when we take that into account, the health outcomes, the harms from it seem to be greater amongst low income groups. So if we could move on, please. Anna again, please. So to recap, there seems to be strong international evidence that place-based approaches to the commercial determinants of health are important in terms of behaviours, outcomes and inequalities. And this last bit of the talk, I just wanted to look at some of the possible policy opportunities, again with a focus on availability. We could move on, please. So again, taking the example of tobacco availability, if we look at the various approaches that have been used across the world, not in the UK, but in many other jurisdictions, the ways in which policy is looked to reduce or address or restrict availability, there are probably 5 sets of policies. Firstly, policies that have looked to restrict availability in what we might think as child spaces, so around schools or around play parks. There are policies, secondly, that look at particular retailer types, so restricting availability to certain types of retailers, maybe to supermarkets or to non-supermarkets or to pharmacies or to alcohol retailing, etc. There are also other approaches which, rather than look at reducing the numbers, look to restrict the times at which the products can be sold. So maybe limiting the hours of sales in relation to the school day might be one approach that's been used in some jurisdictions. There's also a set of policies which you might think about as kind of spatial restrictions, and we see this, for example, in Spain, where there's a minimum distance allowance between 2 tobacco retailers, which of course has an effect on reducing the overall provision, particularly in highly densely populated areas. And then finally, there's other approaches which have looked to where it's required to have a license to sell tobacco, which we don't have here in the UK. But this enables various ways to reduce availability, such as putting a cap on the total number or having other particular restrictions around when it is suitable and appropriate to sell tobacco products. So there's lots of different ways that we potentially could reduce availability. If we could move on, please. And we tried to look at this in some work we've been doing here in Scotland, thinking about the effects of different policies in terms of the distributional and then ultimately in terms of potential health impacts of changing availability. And we did some work with some key stakeholders here in Scotland to identify a series of potential policy interventions, which you can see there, broadly around child spaces, around restricting sales to particular retailer types, and also in terms of implementing spatial restrictions on availability. If we could move on, please. And there are, I guess, 2 overarching messages from what we found in looking at these different sorts of policy options. Firstly, there is a big difference in the overall impact of particular policies, as we might expect, and that sort of, you get a sense of that from this graph. 8 of the 12 policies we looked at resulted in a reduction of availability of about 50%, but some, as you can see on the right-hand side of this graph, had relatively limited impact on the overall availability. So there seem to be big differences between the different types of policies that we might consider. And then secondly, if we can move on, please, the second main point to come out of this work was that there's a very significant equity impacts of different policies. So some of the policies we looked at firstly led to a reduction in availability and also led to a marked decrease in terms of inequalities. So some of the more child-focused examples led to a reduction in availability and to a reduction in inequalities. Other policies led to a reduction in availability but had no discernible impact in terms of equity. And then a third set of policies reduced availability but at the same time managed to increase inequalities. So it actually led to an increase in terms of inequalities and availabilities. And examples of this were policies which were limiting sales to particular types of stores or retailers. So the important point here, I think, is first of all, understanding the impact of these different policies, but more significantly, having some really clearly defined policy objectives when you set out to try and think about how we might reduce the availability of unhealthy commodities. If we could move on, please. So to bring this together, so I think I'm just about out of time and Linda's going to cut me off, I'm sure, any second now. To sum up, what I think we've managed to show here is that in terms of developing action on addressing place-based approaches to the commercial determinants of health is less about a lack of research and evidence. There actually is quite significant international and indeed now UK evidence of a link between the local unhealthy commodity environment and outcomes. So there's significant evidence. What is probably more lacking is some of the policy tools and levers and some of the things that Greg was mentioning earlier on, and particularly that often the policy levers for addressing the commercial determinants of health, and certainly in the case of availability, is often outside of the remit of public health practitioners and sits across different jurisdictions within the policy making environment. So we can see this, for example, in terms of availability. We've looked here, there is clear evidence of a causal link to consumption from availability, yet the availability is driven by economic rather than public health imperatives. And then the final bullet point, I think, here, please. So I think the key questions here are there remaining research and evidence needs to support policy making? I guess that's where Spectrum is certainly trying to work with our policy colleagues to define those and address them. And then secondly, what are the local policy levers to address the commercial determinants of health? And what are the barriers and facilitators, or potentially even the windows that we need to try and address these? So I'll just move on to the next slide, just to say what part of this we're trying to bring online a new mapping platform that hopefully will support policy making. It's certainly been very successful here in Scotland, so we'll share those details. And then I think my very final slide is just an acknowledgement slide, and that's me, Linda.
Thank you very much, Jamie. I really appreciate that. That was excellent. So I'm going to hand over now to Professor Rachael Murray, and thank you, Rachael, for joining us.
Hi, thanks, Linda, and welcome everybody. So I'm going to talk a little bit about maybe some of the prevailing challenges we have with tobacco, alcohol and junk food exposure through various media channels. I'm just briefly going to go through some of the legislation that exists, just because I'm not sure of what people on the call know or don't know, but I'm going to skip through that quite quickly, because what I want to really talk about is what some of the research is showing. Next slide, please. So, everybody that's on this call will already know advertising and imagery of tobacco, alcohol and foods that are high in fat, salt and sugar, or junk foods, HFSS. They're associated with increased smoking, alcohol use and HFSS consumption respectively, and all are associated with health implications and cost to society. And that's primarily what we as Spectrum are working to overcome. Next slide, please. So some advertising regulations then. In the UK, so media advertising is regulated by the Advertising Standards Authority, or the ASA, and broadcast advertising must follow the UK Code of Broadcast Advertising. So tobacco broadcast advertising is prohibited through the Tobacco Advertising and Promotions Act of 2002. But alcohol and HFSS broadcast advertising is permitted, but it's significantly restricted. And there's examples such as banning adverts during programmes and airtime, which is specifically aimed at children. Next slide, please. Online advertising is slightly different. It must follow the non-broadcast code, or the CAP code, which does restrict alcohol and HFSS advertising. It states that alcohol advertising shouldn't be targeted at people under the age of 18 and should not imply, condone, or encourage immoderate, irresponsible, or antisocial drinking. So basically, let's not show alcohol as being a good thing. Junk food adverts also have restrictions, including no promotional offers in adverts that are targeted at preschool or primary age children. But in a recent change and potentially acknowledging maybe the broader reach of online media, all paid for online advertising of junk food, including video adverts on video sharing platforms, are now prohibited. Next slide, please. Looking at media content, so TV, radio and on-demand programming services fall under the UK jurisdiction, which are regulated by Ofcom, and they must follow the BCAP code. Tobacco and alcohol imagery must not feature in TV programmes that are made for children and must generally be avoided before the 9 PM watershed, unless there is what's termed editorial justification. And similar to we've talked about before, mustn't be condoned, encouraged or glamorised in programmes likely to be widely seen, heard or accessed by under 18s. That creates a whole host of discussions in itself about what those programmes actually entail. If we compare kind of online video platforms, the big ones in the UK are kind of Amazon Prime and Netflix. Amazon's regulated under Ofcom, but Netflix doesn't fall under UK jurisdiction at the moment because video on demand services are regulated in the country where they're registered. So for Netflix, which is registered in Amsterdam, this falls under the European Regulators Group for Audiovisual Media Regulators. But the UK are currently in talks to bring streaming services under the jurisdiction of the country in which they're broadcast. So that's something that will hopefully be changing in the future. Next slide, please. Junk food imagery is not currently restricted, where product placement is. If we look at films, so films are classified into age categories by the BBFC, which take into consideration smoking, alcohol abuse, but not food content. And the BBFC also classifies music videos by artists signed to UK music labels into age ratings, which are displayed next to the video on YouTube. Online content is not currently regulated by Ofcom, but social media companies regulate through community standards and terms of use policies, which are, well, they can be very wishy-washy to say the least. Next slide, please. So I'm just going to move into some discussion on the research, but before we talk about the research findings, I just want to give one note on methodologies. So one thing that I'll talk about is viewership, and viewership was calculated from proportion viewership data, which provided by Digital Eye. And then we used mid-year population estimates from the 2018 census data for the majority of the research I'm going to show. We then combine this viewership number with the number of alcohol and junk food appearances to provide what we call gross impressions. So that's how many times these images were seen. And then the gross impressions were divided by the population estimate to provide per capita impressions. So one is looking at people who are actually viewing, and the second figure would be looking at a wider exposure across the UK. Next slide, please. So smoking in Love Island has been spoken about a lot, but it's one area that we do seem to have achieved some impact, so I don't apologise for mentioning it again. The 2017 series received numerous complaints about the visibility of smoking in the context, and so we attempted to quantify this. In short, half of the series episodes that were coded delivered an estimated 559 million gross tobacco impressions to the UK population, and that included 47 million to children aged under 16. Now, this was a show that was promoted by ITV as a massive success with young audiences, regularly capturing a 50% share of 16 to 34 viewers. So this is very much targeting the younger age of the viewing spectrum. And following the results of a research and what ITV claimed was a consideration of public opinion, smoking was subsequently banned from future series. Next slide, please. I'm sorry, can we keep going until the... Okay, so video on demand service. So this study was led by Alex Barker at Nottingham, and it sought to identify any differences between streaming platforms in response to the differences in regulation that I've already stated. We compared a total of 10 programmes, 5 from Netflix and 5 from Amazon Prime, and 5 episodes of each. And we found that tobacco content, sorry, can you move the slide on? Sorry. Keep going. Keep going. Keep going. Keep going. Keep going. That's it. Stop. So we found that tobacco content was in 12% of all intervals of programmes and in 3/4 of all episodes. And alcohol was seen in a similar number of intervals and in nearly every episode that was coded. Next slide, please. So there's no significant difference between Netflix and Amazon Prime in terms of content, but next slide, please. What we moved on to do was to look at difference between the video on demand streaming services and terrestrial television from basically a similar study that was conducted in the previous year. So there was a significant difference between the VOD and the terrestrial television in nearly every category that we coded, as you can see in the table. There was far higher exposure in video on demand platforms than in terrestrial television, suggesting that there are either legislative voids or loopholes that are present for VOD platforms. Next slide, please. So these studies that I'm talking about are all published and the citations are on the slide, so I am going quite quickly through these. Sports is another big area of concern, and this study looking at Formula One was led by Alex Barker. Can we move it on, please? There's some images to come up. And again, thank you. So Philip Morris first partnered with Ferrari in 1973. And tobacco advertising was banned in 2005 due to the EU Tobacco Advertising Directive, but Ferrari still kept Philip Morris Marlboro branding on the car. This was then removed in 2008 as research had argued that it was still Marlboro branding. But then lo and behold, in 2018, Philip Morris launched Mission Winnow, which was kind of a side company, and the branding appeared on Ferrari cars in the last 5 races of the season. And this resulted in an estimated 438 million gross impressions delivered to the UK population. And of those, 14 million were for children. Now, the logos are there at the bottom of the screen. So on the left, you've got Marlboro, and then the 2 to the right are the Mission Winnow logos. And people can use their own judgment about any similarities or otherwise between them. Philip Morris International refused to accept that there are any similarities in the logos on the screen. And there was a quote of, "We put Mission Winnow on the car and somebody told us it looks like Marlboro." And I said, "Look, I think you should go to a doctor, okay?" So these are the kind of responses that we're getting from the agencies. Next slide, please. Moving on to look at football. This study that I'm going to talk about was conducted by Khaldoon Al-Fayed as part of his PhD. And the 2018 FIFA World Cup attracted global audiences, as you may expect, was sponsored by McDonald's and Budweiser, partnered by Coca-Cola, and the official sports drink was Powerade. So obviously alcohol and HFSS brands coming in here. And advertising during sports is really common practice, and it's been identified as actually the dominant medium for promotion of alcohol and drinking in the general population. And as I said previously, Ofcom broadcasting restricts content in programmes, but it's got no remit over sponsorship at televised sporting events. But similarly, the ASA, which regulates advertising, doesn't regulate advertisements at the venue of sports events due to their definition of what constitutes advertising. So in this study, the frequency and duration of appearances to the nearest second of branding was recorded during all active play in live coverage of a sample of 13 matches. And they were the groups featuring England and Russia as the host nation, which has pretty stringent alcohol advertising, and the final game selected because of its potential high viewership. These games were viewed by up to 1/3 of the population, and we identified over 1,800 instances of brand appearances, around 1/3 for McDonald's and Budweiser, 1/4 for Coca-Cola, and 10% for Powerade. And the total duration of all these brand appearances was nearly 1/4 of all active playtime, resulted in 6.7 billion gross branded junk food and 3.7 billion branded alcohol impressions in total, translating to about 852 and 354 million to children. Next slide, please. And then similarly, Alex looked at branding in the 2019 Guinness Six Nations Rugby Tournament. The clue is in the title for the kind of lead sponsors here. The frequency and duration of appearances, again to the nearest second of branding, were recorded during all active play in all 15 matches of the tournament. We identified 3,719 appearances of branding. Almost all were for Guinness at 92%, but actually 8% were on this greatness kind of alibi advertising. The brand appearance were present for about 17% of total playing time. And interestingly, nearly half of all those images were actually superimposed onto the centre of the pitch. And I don't know if you can see in that top image there from the setup, you've got the country flags with the Guinness in the middle. And this tournament resulted in 122 billion gross branded impressions, of which 758 million were to children. Next slide, please. So just from sports sponsorship alone, you can see the significant exposure of children and young people and adults to branded HFSS and alcohol advertising. Figures that I've reported are likely an underestimate because the figures don't account for any online viewing, out of the home viewing, etc. And we know that exposure is likely to be a contributor to alcohol and junk food consumption by young people and adults. So we've proposed repeatedly that advertising and policies should be reviewed to include restrictions on sports sponsorship to reduce exposure to alcohol and junk food advertising through this medium. But what we've also got with sports is a cross-border issue. So host countries may have different regulations to the country in which these sports events are being broadcast. So it's not a UK-centric problem that we need to address. Next slide, please. So finally, I just want to talk about some unpublished data, which has analysed YouTube videos, which was conducted by Emily Mail as part of her Masters in Public Health project. So Emily looked at the top 20 trending videos at 2 p.m. on 4 consecutive Fridays across September and October 2020. Any videos that were up to 1 hour long were coded using a 10-second interval coding, and videos over 1 hour using a 1-minute interval coding. The majority were shorter videos. Next slide, please. So this is the video types that Emily found. So in the total of 80 videos, original videos and music videos were the most common at 36% and 34% respectively. And original videos received the highest number of views, followed by trailers and music videos. And at the point of data collection, these videos had received over 113.6 million views. Next slide, please. So this graph is a bit hard on the eye, so I apologise, but I'll summarise it for you. The most common content in all the videos was HFSS, followed by alcohol, and then followed by tobacco. And there was a similar significant pattern evident when we looked at the intervals. Music videos and original videos contained all types of imagery, so tobacco, alcohol, and junk foods. And the remaining categories contained alcohol and junk food alone. There was no tobacco. The video category with the highest tobacco, alcohol, or HFSS content was sports highlights, followed by original videos, music videos, TV and podcast clips, and trailer videos. This wasn't statistically significant, but when we looked at the intervals themselves, the distribution followed the same pattern, but the differences were statistically significantly different. Next slide, please. I've just picked out some of the really interesting things that we found. So there was a lot around the sports sponsorship, which pulled out very similar things to what I've already presented. But there was one music video and one original video which featured clips of the same video, if that makes sense. And they contained images of a man wearing a shirt emblazoned with rude cigarette packs. So the man in the shirt is pictured top left, and next to it is a picture of a Marlboro pack. And Rude is a clothing brand which has released a range of tobacco-inspired clothing in which the cigarette packets use the same red, black and white colours, the red roof or chevron shape, and the typeface is the tobacco brand Marlboro. And so, yeah, this is very much potentially looking at an alibi brand that's happening. And then on the right-hand side, the video also featured these race overalls sponsored by Moose Craft hot dogs. So Moose is a brand of cider. And Emily conducted quite a significant internet search to try and find out a bit more about these Moose hot dogs. She didn't find anything further other than a website detailing the registration of the Moose Craft hot dogs trademark in 2019, which is the typeface, but nothing else. And you can see, I think, that the logos are very similar, again, suggesting that this is an alibi brand from Moose Craft cider. Next slide, please. And I think the other really interesting thing that we found through this, there was 3 pub quiz videos, all contained alcohol and junk food, none contained any tobacco. Alcohol branding was in 1/3 of all interviews, and junk food was just in 1%. But we identified 4 alcohol brands: Smirnoff, Gordon's, Jack Daniels, and Aviation. and 7 junk food brands, so Dairy Milk, Fudge, Roses, Sprite, Diet Coke, Coca-Cola and Cadbury's. Next slide, please. So these virtual pub quiz live videos contain particularly concerning levels of alcohol imagery in all 3 videos and more than half of all the intervals. So the alcohol branding, as I said, the 4 brands that we identified were in 1/3 of all intervals, but these were limited to week 1 and week 2. There was no branding in week 4. And there's some examples here. So the image on the top left contained repeated shots of the quiz host with different items in the background, as the yellow arrow will point to. So in weeks 1 and 2, there were different combinations of Smirnoff, Jack Daniels and Gordon's pink gin bottles that are clearly displayed in that background image. But interestingly, weeks 1 and 2 were also produced in association with the Drinks Trust, which is a charitable organisation previously known as the Benevolent, who support members of the drinks industry and supported by over 130 industry businesses, including Diageo, who own Smirnoff, Gordon Gin and Aviation Gin, and Brown-Forman, who own Jack Daniels. In contrast, the picture that's on the right-hand side was produced in association with the charity group Samaritans, and the repeated shots of the host featured noticeably different alcohol bottles in the background, branding wasn't identifiable. And I think these findings raise particular concerns around product placement, promotion and brand promotion within YouTube videos. So the platform, as I've said previously, is largely unregulated with these kind of community agreements. And young people's engagement with alcohol brands and social media is again associated with an increase in alcohol consumption. Next slide, please. So I think the overall conclusions from the YouTube videos, junk food is pervasive and it's present in around half of all the videos and every type of video that was viewed. And that's likely a reflection of less regulation of junk food advertising and imagery through formal means. The high levels of junk food branding and imagery in the videos, I think, is particularly concerning. Previous research has shown that these associations between TV characters, YouTube influencers and so on are all really associated with a change in children's food and alcohol preferences, knowledge and behaviour. Sports sponsorship, very similar. If we're looking at unhealthy food brands and alcohol brands associated with an increase in awareness and a preference for these brands and products. And we've shown that it is very widespread with very little regulation. And these pub quiz videos are, almost a new source. They're not things that we've seen particularly previously in the research. With very clearly branded alcohol paraphernalia. And I think we really do need a review of and a tightening of existing regulations quite urgently, actually, to protect viewers from this exposure. Thank you.